Welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Sherry Binns, the Patient's Healthcare Liaison for the MS Focus, and I'm joined tonight by Patty Bobryk, who is a physical therapist. She's going to talk to us about how to manage our symptoms with MS. Patty received her physical therapy degree from Wayne State University in Detroit, Michigan, and her master's degree in neurodysfunction from the University of Florida. She was an integral member of the team that established Orlando Health MS Comprehensive Center in Orlando, Florida, where she provided rehab services for persons living with MS for over 25 years. Currently, she is caring for individuals with neurological conditions in Steamboat Springs, Colorado at UC Health. She has been an MS certified specialist since 2004, as well as an assistive technology professional, assisting individuals to obtain complex rehab technology. Patty has served in many capacities in the MS community over the past 2 decades and has taken several awards for her work. Patty, take it away.
Thank you so much, Sherry. As a rehab professional, of course, I always promote rehabilitation. Tonight, we're going to talk about some tips and strategies to how to self-manage your strategies. But it's always good to visit with a rehab professional, particularly one that has some experience in multiple sclerosis. Rehab can do a lot of things for you, and it's best done in a multidisciplinary approach. That means you may have, besides your healthcare team of your physician, your nurse practitioner, your nurse, you'd have a physical therapist, potentially an occupational therapist, a speech and language pathologist. And what's I feel is most important when we're approaching kind of the intervention that we need for managing your MS symptoms is that it should always be intermittent and ongoing. That means you're checking in with your rehab professional, just like you're checking in with your primary care professional. And I feel that that's important because you want to be able to nip things in the bud before they become too problematic. And if you're checking in pretty regularly, then you're going to be able to kind of address any things that might be subtle symptoms that you really didn't even notice or weren't even that aware of. So rehab can help improve and maintain your function. And we're always talking about having the best quality of life and the greatest level of independence. So rehab can do a lot of things for you. And, you know, we typically think about rehabilitation as improving your mobility, whether it's your walking or your transfers or how you move about. But it's much larger than that. You know, ADLs are your activities of daily living. So rehab can help with those functions that are important to you, whether it's getting in and out of the tub, up and down from the floor, whether it's cooking, also, you know, home life and work life. Rehab can also improve your quality of life, meaning that the things that are important to you and how you feel about your life and how you feel about moving forward in your life. When you have a better attitude, then you have a better quality of life. Rehab can also prevent complications. And I speak to that a lot because, you know, I said already, like we like to nip things in the bud. So let's just use an example that you have a really subtle walking issues. Say you have a little bit of foot drop or foot weakness, and you don't really even notice it, but your walking subtly changes. Now you're stressing joints that aren't meant to be stressed, or you might be using muscles that aren't meant to be your walking muscles. So then somewhere down the road, you end up with a knee problem or a hip problem or a back problem that's more orthopedic in nature. And if we could have addressed that foot problem, the foot weakness early on, we could have prevented some of those complications down the line. And of course, we're always looking for safety and independence. But what we're here to talk about today is providing strategies for the management of your symptoms. And hopefully I have a few tips or tricks up my sleeve that will help you better manage your symptoms. We can go to the next slide. So rehab addresses a lot of symptoms, and we're not going to be able to talk about them all tonight, but weakness, mobility, fatigue, spasticity. We're going to talk some about sensory changes and pain, balance, cognition, speech and swallowing problems. So we're going to hit a few of these, and hopefully you'll be able to take away something that is meaningful to you. Next slide. So the first one we're going to talk about is weakness, and weakness is experienced by at least 50% of individuals living with MS. I really feel that statistic is a lot higher because it is a very, very common issue and complaint. One of the things that we like to look at or consider is that weakness and fatigue, spasticity, and sensory symptoms all can overlap. So sometimes it's hard to tease out if it's really weakness, or are you feeling weak because your spasticity is making it harder for you to move, and it's perceived as weakness. Weakness can develop from the disease itself, but also from disuse and inactivity. And I think that's a really important take-home point. And certainly, I'm going to be talking about exercise, but we lose our strength very quickly. There's a research study out there that they took healthy college guys and they put them to bed for 1 week, and they lost 30% of their strength and endurance in that 1 week's time. So we lose it very quickly, and it takes us a long time to get it back. They followed those college guys in that study for 6 weeks, and it was 6 weeks before they returned to 100%. So I don't tell you that to kind of make it sound doom and gloom, but inactivity really can have an impact on how your muscles work and what your strength is. When you come to a physical therapist, we can't look at you and say, oh, 50% of your weakness is from the disease itself and 50% is from inactivity. But that's the downside. But the upside is the treatment is the same. We would recommend exercise, and we're going to talk about that in the next slide. So we're exercise, energy management strategies, and use of assistive devices are the strategies. So next slide. So when we approach strengthening, you would really ideally want to have somebody who has some MS experience who can truly evaluate all the muscle groups that might be deficient. It's not enough to just say, oh, I want to be on a generalized strengthening program, because if you have limited energy or you have fatigue or any other issues, even time constraints, you want to kind of get the most bang for your buck. So if we determine what muscle groups are deficient or are weak, which ones, if we strengthen them, are going to help you attain your functional goals. And that's most important. We have over 600 muscles in our body. And if we thought about just doing a general strengthening exercise, there might be a lot of muscles that we're addressing that aren't going to give you what you want as far as your goals are concerned. Of course, we want to monitor fatigue, and we'll be talking more about that. The other thing is that sometimes when you're weak, you have a little bit of laxity in your joints. So you want to make sure that your joints are stable so you're not putting a weight on something and causing a joint problem. Next slide. So I wanted to introduce some ideas about how to exercise. And one of the strategies that we use is this intermittent exercise strategy. And a lot of times people come to me and they say, Patty, I went to the gym and I was there for an hour and then I couldn't walk for 3 days because I was just too exhausted. Sometimes we have to shift your idea about what a workout actually looks like. And one of the strategies that you can use is this intermittent exercise strategy. So there's a really good study by Herb Karpatkin, who's up in New York. And in this study, he had folks living with MS on the treadmill. And instead of just having them walk as far as they could, he had them walk for a certain number of minutes and then rest before they fatigued, and then kind of rinse and repeat, and then do it again, and then do it again. So with this strategy, he found that you were able to tolerate a greater dose of walking if the bouts were intermittent. And so if you think about that, if you decide you're going to go out for, and we can use walking, we can use any exercise and go for 30 minutes. And you find that your fatigue really has increased in that, this intermittent exercise strategy may work really well for you. And you end up being able to do a greater workload of activity with less fatigue. Next slide. So I wanted to introduce a couple of newer techniques that we're using in the exercise world that have some good research now for MS. One of them is high intensity interval training. It's kind of the buzzword now. Are you doing HIIT training? And it's really not much different than what we just talked about, is this kind of this intermittent exercise strategy. So say for instance, if we were working on strengthening, and you can use this for strengthening, this technique for aerobic training, whatever you're approaching, but you would do one exercise, say, and these are just parameters that I'm pulling out of the air, but one exercise as hard as you could for 1 minute if you had the tolerance to do that. And then you would have a rest period, and then you would do another exercise as hard as you could, or the same exercise again for that 1 minute. So again, what the research is showing is that you're actually gaining more strength with less fatigue, and you're getting that done quicker than you would in a traditional exercise program. The picture that I have up here is that we were at our annual meeting last year, and there was some nice research that was presented about this blood flow restriction. It's been typically used in the orthopedic setting, but it's basically kind of like a blood pressure cuff. It doesn't completely occlude your the flow of blood, but it does restrict it, therefore blood flow restriction. And if you couple that with exercise, what happens is that restriction in blood flow actually sets up kind of a metabolic condition in your muscle that you actually can get stronger faster. It's kind of like the equivalent of like lifting really super heavy, but you don't have to lift super heavy or do as many reps. So that's just something that if you're going to physical therapy or you're approaching a strengthening exercise, you might ask your therapist about the use of blood flow restriction. Next slide, please. I wanted to bring this up because a lot of times patients, people will ask me, you know, how much should I be doing? What should my goals be? The National MS Society came out with some recommendations for exercise and lifestyle physical activity recommendations. It was endorsed by the Consortium of MS Centers. So I just put 2 little points up here from that document. And if you're interested, it's easy to find. You can just search for it. But one of the things, and what I was really very excited about, that they said in the document that early intervention, early evaluation by physical therapy, occupational therapy, or someone with experience in MS in the rehab world should be done early in the disease, so an individual exercise plan can be put into place. And, you know, that's what I'm always touting, you know, very early on, even if you have minimal symptoms, meet with a therapist who has some experience in MS to kind of get that relationship going and get some exercises that would be appropriate for you. But the actual recommendations were, depending on where you're at, what your symptoms are, what if you have any other comorbidities, should be about 150 minutes of exercise per week. And the great thing about this document is that they not only looked at exercise, but they also looked at physical activity. So like things like cleaning the house, where you might be very active, or gardening, or dancing, or other things. So it didn't just take into account actual exercise minutes, but also physical activity that you might be doing in other parts of your life. So, you know, take a look at that. That would be your goal. You wouldn't be expected to have 150 minutes right out the gate. It'd be something that you would build up to if you haven't been exercise minded in the past. Next slide. I also get questions about, oh, Patty, you know, I'm further along in my MS or I have progressive MS and, you know, what can be done for me in the realm of exercise? So there's some really good research out there to say that conventional exercise, and when I say that, it's just like, you know, regular straight exercises with or without weights or assisted exercise, or other things like functional electrical stim cycling. I'll show you a picture on the next slide where you're actually hooked up to some electrical stim and it's coupled with cycling, treadmill walking, where you're actually supported in a harness. But there is evidence to say, even if you're further along in your diagnosis or you have a diagnosis of progressive MS, you can still improve your cardiorespiratory fitness, your muscular fitness. You can have improvement in your fatigue and quality of life. So, you know, the moral of that story is, one, you know, we're always recommending exercise, and we're always recommending exercise no matter where you are in the trajectory of your disease, because there's always benefits. We'll go ahead to the next slide. So up in the corner there is the gal who is using electrical stim with a cycle. And on the bottom of the screen is a gentleman who's doing treadmill walking, but he's in a harness. So the harness can take some of his weight off of it, off his legs, so he can get a better walking pattern going. And it decreases the risk for falling also. So these aren't things that we really have, that you would have in your home. But again, if you're interested in pursuing some rehabilitation, you might seek out a facility that has some of this equipment for you if that's what's most appropriate for you. We'll go to the next slide. So we're moving on from weakness to fatigue. And again, remember I said that weakness and fatigue are really tied together, as well as spasticity. So fatigue is really, really high in prevalence. Over 90% of individuals with MS report fatigue. And more than 50% report that it's their most disabling symptom, that their fatigue is what's limiting them the most. The interesting thing is that there's no correlation between where you are in your trajectory of your MS early on or later on and the amount of fatigue that you have. So you can have very little disability and still have a lot of fatigue. Gender, it doesn't relate to gender. It doesn't relate to what your MRI looks like or what your clinical subtype is. So that's kind of an interesting kind of sub-fact. It does correlate, and we've talked a little bit about that, moderately with depression and also cognitive function. So there's more fatigue and cognitive dysfunction. Those are linked together. It is one of the main reasons individuals living with MS leave the workforce. Next slide. So to set the stage properly, I like to explain the different types of fatigue. So there's normal fatigue where, you know, you come home from a busy day at work and all you want to do is sit down on the couch and put your feet up and watch a episode of something that you enjoy on the TV. And that's normal fatigue. We all experiencing it. We all experience it. Then there's something called neuromuscular fatigue, or what we sometimes refer to as short circuiting. That happens. Here's an example. Let's say that you decide you're going to go to the grocery store and you start out walking through the first couple aisles and you go, oh, I'm feeling pretty good. My walking's pretty good. I'm doing great, feeling good. And by aisle 3, you go, oh, my leg's starting to feel heavy. And by aisle 5, you're dragging your leg. So what's happening there is that the impulses, because you're working on a nervous system that's not firing at 100%, basically gets short-circuited or wears itself out, or you lose the reserve that you have. So that's the neuromuscular fatigue. There's fatigue that's related to depression, that lack of interest, the feeling that you're overwhelmed, that everything is difficult and a struggle for you. There's cognitive fatigue, and I think that this is really underrated. You know, we don't talk a lot about that. A cognitive activity can actually cause physical fatigue. I may be the last holdout in the whole world of who balances their checkbook, but if you sat down to balance your checkbook, which is not necessarily a physical activity, but is a cognitive activity, and you get up from that, you go, gosh, I'm really, that seemed exhausting to me. That's because the cognitive activity also taps into those energy reserves. There's a special word that we use for fatigue and MS, and that's lassitude. It's an overwhelming sense of tiredness that cannot be attributed to any identifiable cause. One of my patients really explained it to me really well, and she said, I just feel like somebody put a wet wool blanket over me. And there's just such a heaviness and everything is hard to do. All right, next slide, please. So what do we do about it? So the first things that you want to really look at, and you want to be working with, your neurologist and your primary care physicians, or whoever else is on your medical team, to really be able to look at alternative reasons why you might be having a problem before they point the finger at MS. So being able to address any other medical conditions that might be causing fatigue, or even some of the medications that you might be on. That would be the number one thing, to have that conversation with your physician. Now, it might seem contrary to what you would think you want to do for your fatigue, but light to moderate exercise actually can give you a little bit more energy. If you've ever felt like, oh gosh, I really don't want to exercise, but I'm going to do a little bit, and then you do it and you come out of the other end of it and you go, gosh, I really feel better for it. So, I'm not saying that, exercise is going to solve all of your fatigue, but it is still a strategy for managing that. It'll give you more muscle endurance. It'll give you a better cardiovascular status, which will help support all your systems to help manage that fatigue. Certainly cooling, if you're very heat sensitive, the heat can cause some fatigue. And I'm not going to spend too much time on that because we have another slide coming up about heat sensitivity. Energy management, we'll talk about energy management strategies. The other things to consider are your sleep patterns. If you're getting up a lot in the night, whether it's to go to the bathroom or you're just waking up and you're not falling back asleep, I've always said that you can't have good daytime energy if you don't have good nighttime sleep. So that would be something to address with your physician to see if there's something that we can do for improved sleep. And then we'll talk about assistive devices, and then just a healthy lifestyle. When our systems are running at their best, when they get the most fuel, when they're well hydrated, if we're using good healthy habits like not smoking and not drinking to excess, those can help support our body in general and help manage fatigue. Next slide, please. So this is just a picture. This is like Terry. She's on a Schwinn Airdyne bike. Like those because there's a fan in them, so it helps cools you down. It's an arm and leg exercise. If your legs get tired, you can put them up on the pegs and just do your arms, or vice versa. Next slide. So I talked about using energy management strategies, and so what are they? One of them is pacing, and pacing is the same thing as we've been talking about, these intermittent activities. So, trying to find a time that you can intersperse a rest period in before you're fatigued. Being flexible with your schedule, so making priorities for your schedule and to say, okay, these are my top 2 things to get done today. And when I have my best energy, I'm going to do those. And if I have energy left over, then I'll get to the other things that are not so important. Successful use of compensatory strategies. That's a lot of words just to say, can I modify the activity to make it easier so I can save some energy for something that's more important for me? So say, for instance, the activity of showering. If you take a seated shower, you save 25% of that activity, 25% of the energy of that activity. So if it's not important for you to take a standing shower, a seated shower would save a little bit of energy that you could save for something that's really important for you. A lot of times we have trouble accepting assistance, but sometimes if you can open yourself up to the possibilities of having your support systems give you some assistance so that you have energy to really do what's important to you. Home and work modifications, setting things up so that your things that you use the most are closest to you, that, you know, if you're at work, that your computer screen and your mouse and your chair are all in great positions, so you're not using a lot of energy and just an abnormal posture to get the job done. We'll talk about assistive devices in the next slide, but I wanted to bring up about warning signs because warning signs can really help you if you're having trouble kind of monitoring your fatigue. A lot of times folks will tell me, oh, you know I'm getting fatigued when I start getting tingling in my fingers or my vision is a little bit blurry. That would be your red flag to say, you know what, I either need to cool down, I need to stop the activity and take a short rest so that you can kind of recharge the system before you go on. Next slide. So some equipment, you know, most people think about equipment as, you know, canes, walkers, wheelchairs, that kind of stuff. But there's a lot of equipment that's out there that can help minimize the energy that you use. We already talked kind of about a bath or shower bench, taking a seated shower with a long-handled shower hose. Grab bars, if you don't have to work so hard on your balance, if you really can kind of just support yourself a little bit, that makes a big difference as far as your overall energy. Toilet safety rails are a really easy adaptation. It goes on to right onto the toilet, the commode where you clamp your toilet seat onto, and they give you a nice firm surface to push down on to go from sit to stand off the commode, which is really nice because a lot of times folks are that's a struggle for them, or they're pulling on things, or the towel bar, yikes. So that's a nice adaptation. And then certainly if you're having difficulties with your mobility, things like assistive devices, canes, walkers, particularly the four-wheeled walker with a seat, because that works out really great. If you get fatigued, you've got a seat right there for you. And then manual wheelchair, power wheelchair, or scooters as appropriate. Next slide. So I said we were going to talk a little bit about heat sensitivity, and here it is. It's really interesting that it's really high percentage, 80% of individuals develop increased symptoms as a result in their core temperature. And it's an interesting phenomenon what's happening in your neurological system to cause this. So when we raise our core temperature up, we actually increase the speed of the transmission of those impulses in our nervous system. And you think, oh gosh, well, that's a good thing. I should heat my body up because I want those impulses really racing. But what really happens is that you deplete the system out faster. Instead of, if you think of a cup of water and slowly pouring that water out of that cup throughout the day, versus taking the cup and turning it upside down and emptying out completely right away, that would be the analogy of, you know, heating your system up. So you want to do a cool environment. And one of the things that I tell folks is that, you know, some folks don't even realize how heat sensitive they are. So using cooling strategies, even if you don't think that you're heat sensitive, and then you can see how your performance is. But establishing a cool environment, AC, fans, a cool pool, the Schwinn Airdyne, cooling vests and other cooling devices are really a great help. I have some pictures on the next slide. I sometimes have to giggle because some of the research studies that are out there, they're really very practical, but they did a research study to see what's the best way, the fastest way to cool yourself down. And this ice slurry, which is basically, I'm not promoting, but a Slurpee, is really one of the best ways to cool yourself down. So, you know, drinking a really iced drink can really help, you know, popsicles, any cold fluids. And we have our lowest core temperature first thing in the morning. So if you are deciding that you want to exercise and heat is a problem for you, maybe planning that out to do that first thing in the morning might be beneficial. If you're looking for what temperatures suit you best, now this is very individualized, so it's just a guideline, but the environmental temperature should be somewhere between 62 and 66 degrees, which is pretty cool. A lot of folks tell me, well, my family won't allow that kind of cold weather, cold temperature in the house. And I say, well, have them put on a sweater and some socks. The pool temperature is somewhere between 80 and 84 degrees is best. You don't want to get in hot tubs. You don't want to get in a hot pool. And the reason for that is that, if you think that say our normal body temperature is 98.6, you need that difference between the body temperature and the pool temperature so that you can dissipate your heat into the water. If it's higher, if it's in the 90s, there isn't enough of a gradient between your body temperature and the pool water temperature for you to dissipate that heat. So you end up holding all that heat in. All right, we'll go to the next slide. Thank you. So here's some pictures of cooling products. The gal's got cooling wristbands on. She's got a cooling collar on. And in her cap also is a little gel disc that you put in the freezer, and she's got a cool pad in her hat. The jewelry there are, this came off of, and again, I'm not promoting them, but Sharper Image. But that necklace you can put in the refrigerator or the freezer. And if you're going out and you need to stay cool, those beads stay cool. There's another product called Cool Pearls, and it's like a pearl necklace that you also put in the freezer. So you can kind of search for that if you wanted something you wanted to wear out on a nice evening out. That pad on the bottom right is just an example of a cooling product that you could put behind you. So say you were going to a sporting event or you were going to a picnic and you didn't want to wear a cooling vest, or you didn't want to have something, an outward sign that you were using that, you can just put it in the cooling in your chair and lean up against it. Does a nice job. Cooling your trunk in particular, your head and neck are good ways to kind of speed that cooling process. Next picture, next slide. So spasticity is our next symptom that we're going to attack. We have a high incidence of spasticity. More than 75% of individuals with MS will have some degree of spasticity. And just as a little bit of background, spasticity is abnormal muscle tone, an abnormal increase in muscle tone. And it happens because of what's happening in the nervous system. We have parts of our brain and spinal cord that excite things. They're called excitatory impulses. And then we have a part of our brain that is inhibitory impulses that kind of quiets things down. And when we have normal muscle tone, those things I say kind of like the scales of justice. They're like equal. They're in tune with each other. But in MS, they can get out of whack. So you can have not enough inhibitory or too much excitatory. And most people describe it as stiffness or spasms that can actually kind of move your arm or leg when you didn't mean to, or just a general kind of a feeling of tightness. Next slide. So there are things that can contribute to spasticity. Certainly if someone has an infection, one of the reasons for that is that it's going to increase your core temperature. And when your core temperature increases, then a lot of the symptoms that maybe were underlying or were mild can kind of come forward or come to be displayed in a greater degree. Certainly if you're having an exacerbation, your spasticity can be higher. But I brought this up because a lot of people don't think of this, but noxious stimuli can actually increase your spasticity. So if we're talking about tips and tricks of way to kind of manage that, is that if you have a pressure sore, or even if you're constipated, if you have high anxiety, if something's really stressing you out, those can actually increase your spasticity. Pants that are too tight, like the waistband's too tight, anything that your body can view as noxious can increase your spasticity. So just something to think about if you're finding that, oh, I'm a little bit stiffer, what might be contributing to this? Next slide. So what do we do about it? One of the best ways that you can manage spasticity is by stretching, the range of motion. And that's part of what a rehab professional can help teach you to really determines which muscles are spastic and what exercises are best to stretch out. Certainly you'll work with your physician. There are medications that help that spasticity. And they're different than what you would get for like, oh, I lifted too much and I strained a muscle in my back. These medications actually act at the brain level. Aerobic conditioning is a nice way to manage your spasticity, particularly because aerobic conditioning usually is a rhythmic pattern. So something like bicycling or even walking or anything that has this kind of opposite rhythmical pattern to it can help manage your spasticity. Certainly positioning out of the pattern of spasticity. So if your leg wants to draw up or your arm wants to draw up, positioning it outward and also putting some weight on it. So, a lot of times if you've been sitting a long time and you stand up and you go, oh gosh, I'm really kind of stiff, getting some weight through your legs first before you try to take off is a nice way to do that. There are some modalities that can help spasticity. There's electrical stim can help, TENS sometimes can help. It's certainly not front line and certainly not something that not everybody has access to in their homes. You have to buy some equipment for that. Sometimes relaxation techniques can help. And then orthotics, and what I mean by that, like a brace that would position your hand, your arm, your leg out of the position that you're usually spastic in. And that can help. Next slide. So I said I'd talk about stretching. You want to determine what muscles are spastic. And then I recommend a daily stretching program, even several times a day if you're able to get it in. You want to hold the stretch for at least 30 to 60 seconds. If you're stretching really, really quickly, the muscle fibers aren't being elongated and they go right back to where they were. On the other end of that, you don't want to be over aggressive with your stretching. If you're really like, I have some people who tell me, oh, that hurts so good. Well, they don't want it to hurt because what your body will view is that the stretch is a noxious stimuli and it's going to tighten up even more when you let go of the stretch. So that mild stretch, or what I call stretch discomfort, is where you should be stretching at. And of course, you want to watch for joint instability. If you have any other orthopedic problems or there's some looseness in your joints, you don't want to overstretch those joints to make them more loose. Next slide. So, you can self-stretch or you can have be stretching with a helper. This gentleman is also wearing a little wrist brace to kind of help keep his wrist position. So just another technique if you have a helper. Next slide. The next symptom we're going to talk about is pain. And I like to, not that I like to talk about pain, but I think that we don't discuss pain enough with MS. And I think that it's really an undertreated symptom. Up to the 1980s, MS was considered a painless disease. So if you had pain, they weren't relating it to your MS. We now know that 2/3 of all people with MS experience some type of pain during the course of the disease. And the pain can be the result of the disease itself, what's going on in your neurological system, or a consequence of something else that's going on in your body, whether it be spasticity or malpositioning. The positive thing is that pain is not a predictor of poor disease outcomes. So just because you have pain doesn't mean that you're going to have more disability from your MS. Next slide. So I broke it down into some sections here so we can kind of talk about this kind of a little bit more distinctly. There's this dysesthetic pain, and that's that nervy pain, the numbness, tingling, burning. Some people describe it as deep bone pain. You can also have the other extreme of it, and you can have hypersensitivity, whereas like, oh gosh, I can't tolerate shoes on my feet, or the sheet touches me at night and it drives me insane. That dysesthetic pain can be part of the picture for MS. Certainly, we talked about spasticity. Spasticity can cause increased tension in the muscles, which can be painful. And then there can be musculoskeletal pain, which is not really, it's coming either secondarily from your MS because of something else that's going on, another symptom, or it can be from something totally unrelated. And you have arthritis and it's causing muscle spasms that are not of a neurological origin. All right, next slide. So what do we do? Certainly physical therapy assessment and interventions. Sometimes ice can be helpful, but ice is a little bit tricky. You want to make sure that you're not cold sensitive, because the cold can sometimes increase your spasticity and cause you more discomfort. Exercise is certainly important, that movement. What happens is that if you don't move an extremity, if you don't move a body part, we actually get a lot of changes in the joint and the muscles themselves, which can set up a more painful situation for you. So position changes, you know, not sitting for prolonged periods of time, not lying for long periods of time. Support, when I say support, I'm talking more like, well, do you need a support like you need some type of bracing? Do you need some type of external support that's going to help position you better? Maybe a better chair even, doesn't have to be a brace or anything. Maybe you need some lumbar support. And certainly knowing about these things ahead of time so that you can prevent them. We'll do next slide. Sensory symptoms, they're tough. They can be all those things we talked about: numbness, tingling, burning, stabbing, loss of sensation, what some people fondly call, or not so fondly call, the MS hug, this band-like sensation around your midsection, or you could be hypersensitive. And how do we treat that? We'll look to the next slide for that. So there are medications that you can talk to your physician about that are very helpful in managing sensory symptoms. But one of the things that we do in rehab is sensory retraining. And what I mean by that is sometimes when something hurts you or you have numbness or tingling, we avoid touch, we avoid a lot of feedback from our receptors on our skin and our joints. So the body just sets up this system that, oh, there's nothing to kind of intercede or intercept some of these pain signals. So sensory retraining may be something like massage, or it might be compression socks or a glove that you wear. A lot of times I'll give out just a little soft brush in the clinic that you can do some deep pressure with, or some like stroking on it. And it sends a lot of input to your neurological system so that your brain finally goes, oh, they want me to feel this, and I don't have to send these abnormal sensory symptoms down to that. It has mixed reviews as far as the benefit of it, but it certainly can be a distractor when the sensory symptoms are really high, at a high level. Certainly exercise, movement, and knowing about the sensory symptoms, because a lot of times folks are just really nervous and scared about them, like what's happening. I don't know if this is my MS, is this stroke, is this something different? So knowing about them is also very helpful. All right, next slide. So I just wanted to kind of summarize some of the things that we can do just overall, and that's just living well with your MS. So if you're a smoker, please try to find some support for smoking cessation. We know smokers are diagnosed earlier than other individuals who are non-smokers, and they also have more progression. So that's something that you can take control of. I always say, let's control the things we can control. If you haven't exercised in the past, start exercising. And I really encourage you that a little bit is better than nothing. You know, start small, set yourself up for success. And that's what it's really about. We're not training necessarily for the Olympics here. So you don't have to have a deadline that you have to get to a certain point. Slow and steady is going to win this race, and being consistent is really important. Eating a healthy diet, you know, I say garbage in, garbage out. If you're not fueling your body well, then you're not going to get good output for it. The same thing about staying hydrated. I have a much greater appreciation of staying hydrated when I moved from Florida to Colorado. It's so dry here, and the volume of water that you have to drink to really stay hydrated is significantly more. You know, this is just a general rule of thumb, and some people need more, some people need less, but you should be at least drinking half of your body weight in ounces every day in water. So if you're not staying hydrated, that might be a place to start. The next kind of two go together: managing stressors and having a positive attitude. I'm not saying that you have to be excited that you have a diagnosis of MS, but staying positive, staying hopeful, you know, having taking support where you can, to keep looking forward and keep moving forward is really important. And being an active part of developing your own medical plan is part of that, you know, staying positive, feeling that you have some control. Don't forget to continue with your well doctor visits, because that's important. Not everything that you're experiencing is necessarily MS. So make sure that you're taking good care of yourself overall. And then, you know, educating yourself like you're doing tonight, arming yourself with a lot of knowledge so that you feel in control and can make good decisions about where you want your path to go. And with that, I have the last slide, which is a thank you very much. And I think we're going to entertain some questions now at this point.
Thank you, Patty. Bobby, do you want to turn the slides off, please? Thank you. Perfect. We have Patty back. Before we start taking your questions, I just want to let you know how to ask those questions. There's a Q&A at the bottom of your screen. You can type your questions into that, or you can type them into the chat bubble. The other thing that you can do is, if you're on your cell phone, and I see we do have one person that has called in, if you're on your phone and you want to speak or ask a question, you can dial *9 in order for that to be activated. This is also concurrently running live on our Facebook page, and Bob, you will be watching that page if you have questions you want to tick in there. So go ahead and start typing your questions in. One of the things that you mentioned, nobody's got a question in yet, Patty. So one of the things that you mentioned was the intermittent exercise strategy at the very beginning.
Yes.
And some people may not realize how that works. I know I've been to physical therapy in the past, and they've told me they want me to do 6 sets of reps of a specific exercise. And particularly if it's my left side, I tend to lose the ability to move that or to do when I'm doing multiple reps of something. So
Right.
if I do 2 or 3 reps of something and then move to the next category, those muscle groups tire less frequently. And I think nobody took the time to explain that to me. It's something I sort of stumbled on for myself. So if somebody's hearing this intermittent exercise strategy, that's the purpose of it. You don't want to overtire that muscle group, excuse me, when you're exercising.
Yeah, and if I can add to that, and I really appreciate that point for the clarity of that, but if you're going to see me, you won't get a certain number of reps and set. You know, I'm going to set maybe some long-term goals for you. I'm going to ask you to kind of log what you're going to do over the exercise program, but I'm always quality over quantity. So as soon as you start to lose your form, I'm going to ask you either to rest or do something different, and then we come back to it. So, I would rather have you do 10 of an exercise that actually gets the muscle that I'm really trying to target, even if you had to do, 3, 3, 4, to get to that 10 with rest breaks in between, then do 10. And by rep 5, you're starting to substitute a different muscle, because that's all wasted energy. So you want to really get the most bang for your buck when you're exercising.
I think we're seeing more and more physical therapists, occupational therapists, speech therapists that have the initials MSCS after their name, as Patty does. That's a multiple sclerosis certified specialist. And these individuals have worked with people with MS, so they know these little idiosyncrasies that we experience when our muscles tire. Adam has asked a question here. He says he missed a lot of the presentation before getting home. Will the slides and Zoom recording be posted somewhere? Adam, this is on our Facebook page, on the Multiple Sclerosis Foundation main Facebook page, and it will stay live there, so you can watch it there. Within a week or so, it will be on the Multiple Sclerosis Foundation YouTube page, where it will sit indefinitely. So you can watch it and rewatch it anytime for Patty's tips. We have an anonymous attendee that says, the world of MS is small indeed. Today, I started to participate in a research program with Professor Karpatkin at Hunter College in New York City, determining the effectiveness of high-intensity interval gait training. And this afternoon, we posted on our main Facebook page a couple of different clinical trials that Dr. Karpatkin is doing. He does a webinar for us about 3 or 4 times a year on this topic. So for anybody that's in the New York City or Northern New Jersey area, if you're interested in participating in a clinical trial with Dr. Karpatkin, using physical therapy, movement, activity, the information for that is on our main Facebook page. Vincent says, a recently approved device called the Psionic Neural Sleeve, which resembles a thin legging type device having electrode stimulation throughout. Do you have any familiarity with this device? And if so, what feedback have you heard?
I am familiar with the device. It is mainly for foot drop. It's a sleeve that has electrodes embedded in it, and it provides electrical stim. There are other electrical stim units coupled with walking that are out on the market also, Binus, Walkaid. The neural sleeve is on the newest one on the market. It's an interesting concept. They really try to focus on easier access to the patients to obtain it. It's a little bit, it's more cost effective than some of the other devices. So yes, so it's specifically for gait training for walking.
Perfect. We have another anonymous attendee asking, can MS bring out old symptoms from old injuries? Since my diagnosis this year, I've had joint pain that I haven't felt in 10 years.
Yeah, that's a really good question. I think that going back to the point where I recommend that you really work with a healthcare professional that can kind of sort these things out for you. Is it really that the MS has brought the old symptoms back? Or what's the root cause of the old symptoms? Is there something that's happening with your MS that's provoking these symptoms. Maybe your walking pattern has changed, or that you're more sedentary, or it takes more energy. So I think either working with your primary care physician or working with a physical therapist that can help sort that out for you might be a good solution to see if there's some answers to quiet those old symptoms down.
Yeah, I also had a car accident years ago, right before I was diagnosed with MS. And I find that when my spasticity kicks up, the area of injury worsens, but it's in a joint area. And when there's damage to a joint, that comes back to bite you back at times when you're not really well managed. Shelley says staying hydrated is a double-edged sword. I hesitate to drink because of urinary control issues.
I'm sorry, Sherry, can you repeat that, please?
She says she hesitates to drink because of urinary control issues.
Yeah, I hear that a lot, right? So certainly that's an issue, particularly if you have urinary frequency or urgency that, you can't spend your day in the bathroom. But if you can kind of do timed voids, that sometimes helps, that whether you feel like you need to or not, that you use the bathroom to void. The other thing is that, if you plan your day, if you know that, gosh, I'm going to go to physical therapy and I don't want to have to be in the bathroom for most of my session, then make sure that you're drinking well afterwards, that you get those fluids in when you know that you're going to be close to a bathroom. The other thing is that, it requires more planning, really. It's like, all right, before I go into this appointment, before I get in the car, I'm going to void. I'm going to ask whoever I'm with, listen, I need to stop in 45 minutes and we need to find a bathroom. So it requires a little bit more planning, but I can't tell you the decrease in your performance when you're dehydrated. And that's just not for your muscles, it's all of your body systems. We require that hydration to function properly. So I know it's this battle of, give and take, but if you can do a little bit of advanced planning to try to get your fluids in, then try to do that first.
I have a saying, you sip, you drip. And so I recommend that people drink an entire 8-ounce glass of water all at once, and 20 minutes later, they're likely going to be able to completely empty out or very close to that. So if they can hold that and do that timed voiding, they feel like they've really got to go 10 minutes later, go sit on the toilet, try to hold it for as long as you can, and then let it go. But Patty is absolutely right. I know from experience, I've been at this for 45 years now with my MS. And the more dehydrated I am, the more fatigued I am, the more in pain I am, the more spasticity there is, and the less well I think. So try to time that. Betsy has typed both into the chat and into the Q&A that she wishes that there were more MS specialists in the fields of PT and OT. And again, there's a great resource through the consortium of MS centers for information for your physical therapist. And you can give them the website mscare.org, and your physical therapist can send an email to info@mscare.org, and they'll help them to connect with information for physical therapy.
And on the site is listed the MS certified specialists, so you can kind of look at your area. The other thing that I always like to say too is that even if someone is not an MS specialist, it is absolutely okay to interview your rehab team before you go. Ask them what their experience is. If they're not an MS specialist, you really at least want to request somebody who has a neuro background. So one of the other certifications that in the physical therapy world is an NCS, Neurological Certified Specialist. So you might look for somebody in your area who has an NCS. or call the facility you might be going and say, I have MS. I would like to know what the credentials of who I'm going to see. The other thing is that um, I always encourage, if you don't have someone in your area who is an MS specialist, you may be the one that is educating them. And you want somebody who just is interested and would do the homework. I mean, we all started somewhere. So even if you don't have an MS certified specialist in your area, if you can link up with someone who's really going to do their best to investigate, educate themselves, and to do the best job that you can, look for the resources on the consortium website, on the National MS Society website to give the best treatment. Certainly that's a starting point too.
I have two more questions, one from Facebook and one in our Q&A, and that will have to be the end because we're at the top of our hour. But one thing I wanted to say to dovetail onto that explanation is I've had physical therapists before who want me to go through the entire exercise program with the reps while I'm there in the office. I personally am heat sensitive enough and easily fatigued enough that can make it dangerous for me to drive home afterwards. So I ask physical therapists to demonstrate what they want me to do. I do a return demonstration, but not the reps in the office, and that's energy saving. Terry from Facebook wants to asks, I have foot drop. Is it better to try to walk with an AFO or without it?
That's a very good question. An AFO, which is a brace, can help support your foot and give you better gait mechanics. And that's really something important, because if you're using compensatory strategies to make up for the foot drop, then you're really using muscles and joints and putting them at a disadvantage and setting yourself up for something that may not occur for a little while, but down the line cause some problems down the line. Now, whenever I prescribe an AFO for anyone, I want them to wear it whenever they're up and walking. But then I want them out of it and trying to use those muscles when they're out of the AFO, so that you're not taking all of your support from the AFO. So whoever is prescribing the AFO for you, you should be getting some exercises to help augment that. And then the other devices, which are the functional electrical stim, which are coupled with walking, can actually give you a good gait mechanics and help activate that muscle a little bit more. So I don't recommend you just using your compensatory strategies, but to be out of the brace and exercising.
Thank you. Teresa asks, what are your thoughts on the use of hyperbaric oxygen therapy for MS?
I don't feel that there's a lot of research to support that, so it's not something that I'm going to recommend to my patients. There's probably some anecdotal things if you dig deep enough, you know, but it isn't mainstream treatment, and it's expensive. So, you know, my philosophy is, well, if it does no harm and it doesn't break the bank, but if there's not research behind it, then that's not something that I'm going to be recommending.
Thank you, Patty. Well, that brings us to the end of our time, folks. Thank you so much for joining us. If you missed any part of this, as Adam did, know that it will be available on our Facebook page until it goes live on YouTube in about a week. So the Multiple Sclerosis Foundation YouTube channel, and just search for Patty's name for physical therapy, but they should be archived in order of when they were last published. So Patty should rise to the top when she goes online live in the next week or so. You'll be receiving a short survey when you leave the Zoom part of this conference, not when you're on Facebook, but when you leave Zoom. We ask that you take a moment and answer that survey. It helps us to plan on topics that you feel that you need to hear. Our next offering will be this coming Thursday, November 19th, and it will be Dr. Barry Singer talking on innovations in MS care. So Please stay online for that survey. Patty, thank you so much for taking the
Thank
time.
you. My
Yeah.
pleasure.